Hey everyone, welcome to this version of the virtual Fireside chat. We're going to be talking about building cultural considerations in O&P facilities. My name is Matt Bulow. I'm happy to be hosting this event. I'm currently serving on the AOPA Board of Directors. Recently left patient care after over 33 years. Had Bulow OPS, BCP group, and then ultimately that turned into 4Motion, where I was the national clinical director. We have this discussion is hosted by AOPA's Committee on Access, Representation, and Empowerment, which which works to help the profession strengthen inclusion, expand opportunity, and improve engagement across O&P. This is really important here. Delivering truly patient-centered care requires more than clinical expertise. It requires awareness, empathy, a willingness to understand the varied experiences, backgrounds, and perspectives that patients bring with them into the care setting. So today's conversation is one that I'm very passionate about. I've always felt like there's two important aspects to what we do. There's the technical side, and then there's the true care side, the personal touch of what we do. That's, to me, just equally as important. So we'll explore how clinicians in O&P facilities can strengthen this patient trust, the communication, and improve outcomes by integrating cultural considerations into everyday practice. In a nutshell, it's the importance of showing our true care by meeting patients where they are. So just two quick housekeeping points. One, the session is being recorded. And number two, if you have any questions, please just put them in the chat, and we'll try to leave some time at the end for Q&A. So I want to start by briefly introducing our four speakers today. First, we have Mandy Rett, who's an assistant professor from Baylor College of Medicine's Orthotics and Prosthetics program, and assistant dean of community health for the School of Health Profession. Her work focuses on education, scholarship, and strengthening inclusion learning environments in healthcare education. So, Mandy, thanks for being here. Next, we have Michelle Hall, who's the lead prosthetist and O&P residency director at Gillette's Children's, and a fellow with distinction of the American Academy of Orthotists and Prosthetists. Michelle is widely respected for her work in clinical care, research, and mentoring the next generation of our clinicians. Third, we've got Dr. Michelle Walcott, who's a professor in sports medicine orthopedic surgery at the University of Colorado. Sorry, I occasionally root against them, but that's a different conversation. But I'm a Notre Dame fan, and no one roots for them. She serves as team physician for the University of Colorado Athletics and the Colorado Mammoth, and is deeply involved in patient safety, advocacy, and health athletic care. And then finally, Samantha, last but not least, Samantha Strong is a senior HR organizational development consultant with the UVA Physicians Group. She works closely with healthcare leaders and teams to strengthen the workplace culture, leadership development, and communication across diverse teams. So thank you for joining us, and thank you all for I know everyone's busy and giving an hour to this important topic. So real quick, we're going to break up the next 45 or so minutes into four sections, and we'll spend 10 to 12 minutes on each. And I'm going to just ask the four some questions and get their insight on them, and then we'll end with some Q&A. So our first topic is a discussion on setting the foundation. Like why do cultural considerations matter? So maybe I'm going to start with different people here. Mandy, maybe you can lead us off. How do you define culturally responsive care, and why is this important today?
Sure. So I would define culturally responsive care as taking what we do as orthotist prosthetists and dividing it into two areas. There's our negotiables and our non-negotiables. We have a device that we are creating for our patient, a custom device, and that device has specific biomechanics involved in it. And some of that is non-negotiable, but the other part, the patient actually integrating this device into their daily lives, perhaps what it looks like on the outside, perhaps how they're going to adjust their lives with this device, that is something that needs to be worked out between you and your patient. And that does require a relationship. And so culturally responsive care means that you are tapping into that side. You're having conversations with your patients. You're listening to your patients about what's important to them. Because if you don't understand that, then that device that you're providing for your patient perhaps is not going to be as effective as it could be. So that's when I think about culturally responsive care, we're responding to what's really important to our patients beyond the function of the device.
Joy, we're done. We can skip the next 54 minutes because that's fantastic. That's awesome. Thank you so much for that. This is my last Notre Dame reference, Dr. Walcott. Is I thought when she just said that, Lou Holtz, who just passed away, he always used to say, "Do the right thing." And it's funny, it just popped in my head when she was saying that. Is you do the right thing on this listening and so forth. So that's awesome. Michelle, can you add your thoughts on that?
Yeah, I was
Yeah.
gonna.
Oh,
Oh,
sorry,
sorry, go
which
ahead.
Michelle?
Oh, I'm sorry, Michelle Hall.
Sorry.
Sorry.
Sorry. Hi, everyone. Mandy, I really appreciate the way that you structured that, and I'll just frame it slightly differently, but I think you'll see a lot of the parallels to it. Is I think of it similar as part of our evidence-based practice model, where we take the best available published scientific evidence. So that could be about culturally responsive care. It could be about a person with cerebral palsy diplegia or AFO, all of that information. And then we're taking the patient's cultural beliefs and preferences, and then our own clinical expertise to make that plan of care. And this would give consideration not only to their intersexual identity, such as like race, gender, class, sexuality, ability, but also what the research and the clinicians recommend. And I think that's really important. I think 2020 highlighted a lot of inequities in our healthcare system, globally as well as in the US. And those health disparities, I think, perpetuate when there's that lack of trust between patient and healthcare professionals. So I think it's imperative that we as healthcare professionals first understand the patient's beliefs and then tailor our care to them. And I do hold strongly, I liked what Amanda said about the negotiables and the non-negotiables, because most of the time, whatever treatment plan we're designing, there are some areas where we can negotiate with that patient and we can accommodate what their identities and beliefs kind of lead them to, or personal preferences.
Yeah, great. Good. Thanks for that. I just think it's such a core question. So I'm going to have all four add, if they would. Dr. Walcott, could you add any thoughts you have?
Yeah, and I apologize. I didn't mean to interrupt Michelle because I have no negative feelings about Notre Dame whatsoever. I have friends and family that went there, but I actually have a slightly maybe different perspective because as an orthopedic surgeon and I do sports medicine, so I'm not as involved in your world, although sometimes we are, particularly with some of our disabled athletes. I think it's really a matter of just creating a safe environment. When anybody feels safe in the environment they're in, and that can be in various ways, just having, a chaperone, a witness, somebody there to help them remember what you said. Maybe a family member to sort of hold their hand, or maybe someone they don't want in the room. Um, just creating a space where they can actually tell you what it is they're looking for and what they want to get out of that visit or interaction. Just taking a moment to pause at the beginning of it.
Yes. Yeah. I'm actually going to come back to that last point you made in a bit. Thanks for that. Samantha Strong, could you give us any additional thoughts on this? I know you're fourth, but still.
That's okay. I was trying to think. I was like, oh, wow, that's hard to follow up with the last
Exactly.
one to go here.
Mm.
And I too am coming from a really different perspective here as well. I am not a patient facing, I'm not in patient facing areas. I support all of those of you who are seeing patients. So I often talk about my role is to make sure you're supported and my team at UPG are supported as they go in. One thing I was trying to think of, oh my gosh, this is so good. What can I add? One of the things that I love to remind our teams of is when they're taking these considerations in, when they're seeing the whole patient and patient first and seeing the values, the previous experiences that they've had, that people have had in healthcare, the cultural differences. When you see all of this, you're not only engaging in a space that's providing amazing care to your patients, but it also makes an impact on your team as well, because that starts to bloom out. And then we start to really create these practices, these departments, these clinics where it's not just the patient that's receiving this cultural responsive care and this understanding. We also see that start to really affect our team members who are coming in as well, and that acceptance and inclusion and belonging and all of these things start to spill over. So I love that we're having this conversation. I'm grateful to be a part of it because it can really affect a whole department, a whole clinic, when we see it in that big picture.
Yeah, I've got to chime in on this real quick. What you're saying is two things. One is that I'm hearing is even if I wasn't patient facing, we're still all people. You have to go see someone for healthcare. Your loved ones have to go. So you can still do for others what you wish someone did for you. Like you go to a doctor's appointment and it was just the most amazing care from the front desk all the way through the MD. And I would absolutely steal their ideas. Or unfortunately, sometimes it wasn't ideal. And I would say, no matter what, we're not going to do this. So yeah, even if it's not you're specifically in O and P, it's still people treating people.
I firmly believe that this is all about a conversation. And that's what I love today is it all starts with a conversation to really start making these big changes. And I love the idea of having this conversation today.
Well, let's reverse it just to be really fair here. And Samantha, you're going to go first. I want to skip to let's. This may not be ideal for you, but anything that you want to add is for O and P specifically. What makes culturally responsive care especially important? Anything you can add to that is even.
I was going to
And
say, let me go first because this amazing group is going to have way more experience
okay,
with this. But from the time that I've spent with our teams here at the physicians group, what I've learned is this is a long-term relationship that is built. It's not just, well, they're coming in for this test and hopefully they'll be back in 5 years when they're supposed to do it again, right? This is a long term, this is a relationship that's being developed. And I am very proud of this group for starting this conversation. Like I said, I'm not patient interacting, so I'm going to let my colleagues here talk about their exact experiences. But I think that that is one of the key things is that you are developing long-term relationships with the patients that you're seeing.
great point. Dr. Walcott, do you have anything to add on this? O and P specifically or similar?
I think the only thing I can probably add to that conversation is it's important to know what your resources are and what you have to offer in your system. Because if I don't know when I'm referring someone what I can offer or what my system can offer, I find that to be frustrating. So I think just knowing that, understanding that, or seeking it out if you don't know.
Yeah, yeah. Michelle Hall.
Yeah, thanks. I think to add to what's been said, and specifically that kind of long-term relationship building that we do as clinicians, would be to add that O&P is so visual. We're making it like the care we're providing is a device. I mean, it's so much more than the device, obviously. But one component is the device and it's visual. People see it. People see it on people's bodies, right? So many patients, if we're doing things really well, they incorporate the orthosis or prosthesis into part of their body image. And body image is innately personal, and our cultural beliefs play a role in that embodiment. And so it means that it's imperative that we learn the patient's preferences so that we can tailor it to their care. And I think to Dr. Walcott's point, we need to know what the resources are. So I need to know what I can offer for the visual representation of that patient, not only from a biomechanics standpoint to meet that patient's needs, but also from a visual standpoint.
Yeah, Michelle, I'm curious to pick your brain a little on children specifically. I lost my leg when I was 14, and I had never thought of this until last week. Somebody asked me, I just met them, how many different prostheses do you have? And I said, honestly, I could have as many as I wanted. I'm fortunate in that way that, with my connections in the clinics and so forth, I literally have one. And the reason why, and maybe it's a little weird, is because it's my right leg. And if there's some weaknesses in it, it's like, yeah, but the guy I'm playing tomorrow in whatever sport is, he has a weakness in his knee. It's arthritic or whatever, but it's just part of my body. And I want to be clear, things like so everybody can move and so forth, I'm hugely supportive of. But it struck me of that. I guess I had truly incorporated it into my body. Like, this is my right leg now. So just a little side story there.
Yeah, that's great to hear.
Yeah, anything on the children that you think of specifically in this subject?
I mean, I think one of the challenges that we face as like pediatric based clinicians is that parents have certain preferences, patients may have different preferences. And so it's balancing, even as we see our patients in adulthood or early adulthood who are fully capable, age appropriate to make their own decisions, their parents may still have opinions that are swaying that patient. So needing to acknowledge everyone's opinion in the room and then ultimately have to, kind of balance that. And every family is a little bit different of, if we give them what the kid really wants or thinks they want, there may be unfortunate retributions at home. We've run into those issues where the parent who's not there, we know is going to have a lot to say about that to the child, and we don't want to put the child in that situation because they don't understand that. So I think there's different things that we just have to, I think it goes back to what I think Samantha had said about building that trust, right? And what we all said in the initial statements of understanding our patients and where they're coming from is so crucial to then be able, especially in pediatrics, but I think at all ages, to have those discussions and balance that.
Yeah, thanks for that. Mandy, anything to add on just O&P specifically? What makes culturally responsive care so important?
The only thing that I would add is I was piggyback off of what Michelle said about evidence-based practice. I think the culture of evidence-based practice is creeping into orthotics and prosthetics even more than what it is. And so transferring that culture of evidence-based practice to our patients is also great too, that we have some evidence behind all of these interventions that we are suggesting and recommending to them is important as well.
Yeah, great. So, okay, that's great. That was section number 1. We're going to move to section 2 now, and this is experiences from O&P. Why don't we start with Michelle Hall on this one? Can you share an experience where cultural understanding or lack of it, because remember we said we can also learn from our weaknesses or failures as well. Can you share an experience where cultural understanding or lack of it significantly affected a patient interaction or outcome?
Yeah,
Yep.
Sure. I'm happy to attempt that. It's definitely a hard one, but one with lived experience so we have in the great state of Minnesota, in Minneapolis specifically, we've unfortunately been in the news a lot. We have a large Somali population as well as a large Hmong population. And within the Hmong community, at least one of my patients' families had shared with me that they, in their community, it's really important to be buried whole. So when one of our patients unfortunately passed away, they wanted to make sure that there was a cover on the leg prosthesis so that they appeared whole and could be buried with the prosthesis. So we had to do that for them, much willingly to help the family in any way possible. On a more lighthearted note, in the same community, one of my coworkers who identifies from that community shared with myself and some coworkers that a patient had told him from the same community that a clinician had patted their child on their head, which is like something very familiar that I think like grandparents in some communities might do to their grandkid, but that's a family member, not a community member. And within their community, that is really frowned upon. Like that's incredibly offensive. And then similarly, a patient has shared with me that thankfully I didn't do these behaviors, but that the kind of doing, and I'm going to do this acknowledging that it may be offensive to some, so my apologies, but the motion of either taking your hand and doing this to draw someone towards you or a single finger and drawing it towards you in certain cultures is really offensive. And so just like learning those little things and being open to learning from my patients has been really crucial. And then one last anecdote, sorry, is just again with the Somali American community that we have here in the Twin Cities. A lot of individuals are very modest in their dress. So they may have head coverings, they may have facial coverings. The women in particular, I've learned from them that they are not comfortable being alone in a room with a man that they don't know. So those women who need, say, a KFO, I end up, or one of my female coworkers ends up caring for them. And when we're in the room, they are then taking off their headdress, and I'm seeing all the beautiful colors and such that they're wearing and learning, from them. But they're willing to raise their skirt or dress so that I can actually do the care that I need to of inspecting their limb. And so I think understanding, it goes back to what Dr. Wolcott mentioned of knowing your resources. So one, understanding the culture of the individual you're caring for, but then what are the resources? So in that example, our male practitioners are well aware of it, and they do offer for those patients, say a woman that modestly dressed from the Somali community who has a CAFO, to offer, I'm more than happy to see you. I'm happy to bring in one of my female coworkers, or we can just have a different coworker see you. What would you prefer in allowing them that opportunity?
Yeah, I those specific examples are great anecdotes to share. I learned something. Fortunately, I was in the last class at Northwestern with Gunther Gell, who's an amazing professor, and effectively what he taught us is you're going to make mistakes, like the pat on the head or something is, and you know, I also harken back a little to the negotiables and non-negotiables is you are going to make a mistake, but if the overall feel of how you're providing the care, they know you care about them, but you slipped up there. Basically, his point was, oh, you're going to get a pass, but you know, you're not leaning on that for the pass, but it sure is nice to show, you know, consistently that care where you get away with a mistake like that.
Yeah, and I think a really good example is individuals' first names
Wow.
or last names, right? Their name, that when I say someone's name that's not their name, I don't perceive as being from my culture or my identity, I will with humility try to pronounce their name and say, gosh, did I get that right? I'm so sorry if I messed it up. If I say it incorrect again, can you please tell me? Because I legitimately want to know. I don't want to call someone by their wrong name. And so just I think having that humility goes a long way, like what you're saying, Matt.
Amen. Dr. Walcott, anything sharing any experiences where this good understanding or lack of it affected the outcomes?
Yeah, I mean, I just recently had an experience. I'm not sure exactly how much it relates, except this was a gentleman who was a below-knee amputee that sustained a tibia fracture. I didn't end up treating that, but as a result of his treatment, he had a flexion contracture. And he came to me to get his knee scoped so that I could help him get his knee straight again so that he could wear his prosthesis. And so maybe this goes to some of the things you guys were talking about where I had to be creative and thoughtful, never having done that before. How could I do it? How could I get leverage on the limb the way I normally would with a longer limb? And then after, not just in surgery, but then afterward, I've used several devices to help achieve knee extension in this case that wouldn't fit him. And he's a very smart older gentleman. I would call him a little bit crusty, but he appreciated me being very forthright about this. I don't actually know how to do this. I have some ideas. I understand some biomechanics. Maybe you can help me. And we partnered to get him into a type of I don't even call it a brace. It was basically a board that we got him onto and using different kinds of straps and pads. And I actually really enjoyed that process with him. And I told him that, and I actually thanked him, which made him then he wants to come back to me for care that I don't provide, but because I engaged with him. And I think like that's being sensitive in a way where you can actually learn and enjoy from that experience. And I've been in practice for 23 years. If I didn't learn from almost every patient that I see, I'd be bored and I would
Yeah.
probably retire.
Yeah. Yeah, it's interesting what you're saying there is you actually gained more trust by not having all the answers. And then the
And
other thing I
admitting it.
thought, and admitting it, and the
Yeah.
other thing I thought of when you said that is then soon there's going to be a time where you are 100% right and you know you're right. And when you say it that way, I feel like he's going to be much more willing to listen. In other words, like, well, she didn't act that way when she didn't have all the answers. So now that she kind of does, I'm going to shut up and listen. So
I
I
hope
like that.
so.
Yeah, I like that. I like that. Samantha, strong. Bring a strong answer here on some uh, actions that either positively or negatively, if you don't mind.
These everything I think that I could think has been hit on the idea of being humble and having that humility and knowing we are all learning. I laugh and say I've been doing organizational development, DEI work for years, and I still get things wrong. And I still have to say, oh, I'm so sorry. Hang on just a second. I learn things new constantly. So to understand and come to terms with the fact that we are never going to get it right 100% of the time when we are working with and interacting with cultures and people and just anyone outside of what we are accustomed to. And to go into it with that humility and with that desire to learn, I will always look for any reason to use a good Ted Lasso quote. So I constantly say to everyone at UPG all the time, get curious, not judgmental. The more curious we get, the more open questions we ask, the more time all of you spend with patients just knowing their story and
Mm.
taking a second. And that's hard. I know it's really hard, but taking any extra second you can to get to know who they are and what is important to them, it goes such a long way in those relationships.
Yeah, and to your point with that is a lot of new developments. Coming out that is going to save us time in fabrication, 3D printing and so forth. And boy, if we could steal 3 minutes of where we would have been pouring a cast and instead getting to know them or build that trust a little bit more, boy, we could really enhance our care. Amanda, any thoughts on this? Any experiences, positive or negative, that you could share?
Sure. So it made me think of an experience working with a patient. I started my clinical career at Shriners Hospital. And so this particular patient from a particular culture, I learned was very apprehensive about charity care. And so this particular patient, this kiddo that I was seeing, 8-year-old BK, the father wanted a stainless steel pylon because he thought that the aluminum pylons that we use were were not sufficient. And so he argued me down, stainless steel's better, stainless steel's better. So I kept on, I had to counsel him on the standard of care for aluminum. And it turned out that he was mistrusting of charity care. He thought that because they were at a hospital that had charity care, that they were getting less than. And so once the family understood that they weren't getting care that was less than the standard, they were okay with what we were recommending. And so that actually helped me with other patients, kind of from his demographic, from that family's demographic, understand that they were foreign, understand that charity care perhaps in their country is less than. And so it's those little intricacies that you might not have learn about unless you really ask questions and interact and repeat yourself in a different way that you can get that information from your patients.
Yeah, yeah, that's good stuff. Thank you all for those really good answers. I've got two, just let's get a couple quick hits on this if you have them. Two other questions in this section. What have you learned from patients that changed the way you approach communication or shared decision making? And or trust is foundational in O&P care, as we've hit on a number of times already. What strategies help clinicians build trust across cultural differences? So trust building, anything you've experienced that changed your care, any quick hits on this? And let's start with you, Dr. Walcott, please.
Yeah, I think Samantha hit it straight on with be curious.
Hmm.
And then, then I follow that up with um, engaging more the questions about who they are and what they're looking for. But even a simple thing, if you have a patient that doesn't speak English as a first language or maybe not at all, I'll usually ask them like, what in your language, what is the word for this that's relevant? Say it's knee or shoulder, something really relevant. And then I'll try to learn it and use it with them, even if the rest of my conversation is in my first language, which is English. But it just helps them understand that I actually am interested and I'd like to learn from them. And so just small things like that, I think can really help.
I love that. I scribbled down three notes for today, and one of the three was just what you just hit on. Is one thing that I would do lots of times is when you're starting out and you're getting a history, and people are going to tell you if you give them a minute what's really important to them. And as the appointment progresses, or even the next appointment or two, we reference back to it. Is hey, you had talked about just, the look of this was really important to you. So I was kind of between this or that, and let's go with this because that addresses that. I feel like that really signals like, wow, this dude's really listening. He didn't just ask the questions because it was on his page. That's one little trick that I would use that not a trick. That sounds like I'm playing them. I'm not. It's almost checking myself up too of did you address those two or three things that they said were super important? Samantha, anything you want to add to these?
Anytime you give me an opportunity to talk about trust and developing trust, that's one of my key things that I love to go and talk to teams about. I work on it in leadership development a lot because I have so many leaders that'll say, "Oh, but I held this group to ask them these questions and no one answered me." And so I always have to remind them trust is built through consistency. And so that's one of my things I always like to give as a takeaway when I'm talking about trust. You can show up, you can meet one time and bring your A game, and it's awesome. And they had a great visit and a great appointment, and you're like, oh, yeah, we've got it now. But again, if you haven't done that culture, that understanding, that deeper understanding, we don't know what their history has been. It's going to take more sometimes for someone to trust you. They need you to consistently show up that way. And I loved the Shriners example. What my one of my friends is with Ronald McDonald House, and it's same like to show up that way consistently, and then you earn that trust because they see, oh, this is the way this person is all they genuinely care about me. This isn't what it used to be when I had that bad experience. This person cares, but it takes consistency. They have to see that each time. And that's one of the things I love to drive home when trust comes up.
That's good. Good stuff. Amanda, anything here?
Just to reiterate relationship building, I think specifically when it comes to shared decision making, a lot of times we're recommending things to our components, things to our patients, and how do they know that it's the best thing for them? It's through that relationship that we have that they know that we have their best interest as from a patient practitioner standpoint in mind.
Yeah, great. And Michelle, I don't think you've been in on this one. If you have anything to add, it'd be great.
Yeah, I mean, I think I would just echo what others have said, that just approaching each patient with curiosity and humility is really the key. I think it's equally important for me to know my patients' cultural beliefs and practices as it is for me to know their hobbies, because both can equally affect the design of the prosthesis or the orthosis. And so learning from our patients and then really offering solutions that can help make that final decision and really do that patient-centered care where the patient and the family really are helping to design, like create that final design, I think is so critically important. And the research, I think, points to supporting that approach also.
Nice. All right, we're going to go to our third section of 4, and it's all about communication, which we've talked a good bit about already. But I think it's important to hit it again. Communication and care delivery. So just some thoughts here, and then we'll go around the horn on these and answer it in any way that you want. I'm going to give all 3 questions that I have down here. One is, how can providers ensure that they're listening effectively and avoiding assumptions? Also, what role does language, terminology, or health literacy play in effective communication? And finally, what are some of the barriers clinicians encounter when trying to implement culturally responsive care? So just talking about, in general, we're talking about our communication with our patients and the care delivery. And why don't we start? Dr. Walcott, can you lead us off on this one?
Yeah, you gave like 3 big questions. So I'm trying to figure out how to
I know.
summarize it.
Yeah, anything to do with listening effectively, communicating effectively with them with cultural responsive care in mind, and any barriers, just anything to do with the communication in general.
Yeah, I'm gonna point out one of the things that it occurs to me when I'm talking to a patient and I'm trying to get information from them, and sometimes I'm trying to be too overly sensitive. And I'm not getting the information because I'm talking around it because I don't want to offend anyone. And in those scenarios, when I find myself struggling, I'll just come right out and say it. You know what? I'm really just trying to figure out. I'll give an example of this. I had a patient that had multiple tendon ruptures, like an Achilles tendon rupture, then had a biceps rupture. And I was talking to them about how it's so much more common in men. And I'm trying to figure out why she keeps having these unusual ruptures and if there's some underlying pathology. And I didn't say that. I just kept saying, maybe you're going to the gym a lot. I forget exactly. Are you using steroids? Um, but what I was trying to get to is this person to me seems like someone who might be transgendered, and I didn't feel comfortable asking that. So I said, the reason that I'm asking these questions is this is just much more common in men. And she said, oh, well, let me tell you. And that's how it came out. And I remember thinking in that moment, I'm so glad I just asked. I was sitting here awkwardly trying to talk around it and not to be offensive, but because I had a real purpose in knowing that in terms of, prevention strategies and other things that affect genders differently. So just be honest about it. I will admit I'm probably gonna stick my foot in my mouth with this question. Here's why I'm asking, and if I could, and even ask for help, like what's a better way I could get to this that maybe wouldn't offend you? Sometimes they'll say, that doesn't offend me at all. Now I understand why you want to know. That makes sense. I want to participate in my care with you. And so that I find that to be sometimes a barrier, but I think there's a way to just push through it. Say, you know what? I don't know how to do this. I need your help.
I think it's. I really appreciate you sharing that. I'm gonna share a really quick one that's somewhat similar. Is I got a referral from a physician, and the physician, she said, whatever you do, don't say she or her, whatever you do. And I went in like I was so set that I wasn't going to say it. And darn it if I didn't say she or her 7 times.
Well, it's in your head
But you know
now.
what? Yeah. And I'm not at all dismissing that we should try. Okay. However, what I did do is for about that hour-long appointment, I really cared, and I really showed that I was there to do better than she expected, better than they expected. And she was not remotely offended after. I can't remember if I said something or not, but I could just tell after. I was thinking, oh my gosh, I did it like 7 times. And no offense whatsoever. So I think the key here is you're trying and you obviously care. That's what I think. I might be wrong, but it works generally well. Samantha, can you lean in on communication, care delivery? Any thoughts with that? Any barriers that we encounter?
Yeah, so I was also trying to process those 3 big questions and what to say. And to
Yeah,
your
sorry.
point, Matt, that you were just saying though, humility. Michelle said it before, and it's so key to say, oh my gosh, you can correct me. Please teach me. Like, I don't know what the right thing to do is, and I don't want to get it wrong. And 9.5 out of 10 times, I've received love and kindness in return when I've done that. The thing when it comes to communication, I was just working with one of our teams this week and reminding them that communication is 2 parts. It's not just in how well we communicate. We were talking a lot about jargon and making sure we're using words and communicating in a way that the patient will understand. But I also told them, I was like, that is really important when we're talking about communication, is how you're speaking. But there's another half to communication that we lose, and that's how well are we listening. And it's really important to remember to communicate well. You have to do both of those things really well. You have to actively listen and ask questions and ask those curious questions when you're getting in there. And then I always like to talk about the power of a pause. Somebody else on the panel mentioned like pausing too, the power of a pause to stop and think about it before you respond, or to always ask yourself why when you make a decision. I do a lot of classes around UVA on bias in healthcare and how that can influence health outcomes. And I always tell them like it's actually not hard. You just need to stop. Just stop and ask yourself the why. Did I do that? Why did I think that? Why did I say that? Am I seeing the full picture here before I move forward? That's really powerful.
I've got to throw in another really quick story on this. Is one thing I always would teach young or new CPOs is it's easier, in my opinion, to be a good listener, a good pauser, and so forth when you've done 5,000 BKs. I mean, it just is. When you're on your 16th one, you're thinking through whatever you do. Don't forget this and this. And one tip that I always would give is have all your stuff perfectly organized, right in order. Have your saran wrap sitting there, have your plaster already out of the packages sitting there, have your bucket of water sitting there, have your measurement. Then it just takes that brain space, frees it up so that you can be more present and listen and so forth. That's one tip that I always did myself and would advise. Amanda, any thoughts here on communication and care delivery? Please.
Sure. So it makes me think of, and you all have probably already doing this, is the patient interview can turn into, can you all hear me? Okay. Okay, you froze for a second.
Yes.
The patient interview can turn into a conversation. And since I'm on the education side and students are learning how to interview, they have a sheet of paper in front of them where they're going through a list of questions. And so, out there in clinic, when you do have your 5,000th BK, you can disconnect from what am I actually doing procedure-wise and have a conversation with your patient. Don't ask your patient about comorbidities. Ask them about maybe a specific diagnosis if they're taking a specific medication, and then tell them why you're asking, because they're going to say, oh, I'm in perfect health, and you have all these issues and problems, and that will affect the fit of their devices. So for communication, we get away from that list of questions. We get away from perhaps sitting in front of a computer screen and typing in the actual answers to the questions for our EMR. And just sitting in front of them, eye contact, having a conversation because you've done it multiple times. And also, after you see the patient and they come back for a follow-up, you're asking them a follow-up question about something specific that you heard in the last patient and encounter. So those are some of the things that I've seen and used myself that really help cultivate that relationship.
That's awesome. Really good stuff. Michelle Hall, anything to add on communication, care delivery,
Yeah,
and so similar?
Sorry. Yes. Taking Samantha's comments maybe a little bit further of like the active listening. I think it's all behaviors that we could take more practice in, and I just fudged on right there as a good example. But I had the opportunity at Gillette Children's early in my career to take Crucial Conversations. It is a book. I get no credit for recommending it, but it hands down one of the courses that I most strongly recommend for our residents and new clinicians at Gillette. In it, they talk about being like talk tentatively and testing your assumptions. And I think that dovetails really well to this topic that we're talking about right now, where you start with phrases. And I've actually seen each of you model this a little bit today of if I'm understanding you, blah, 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 or help me understand. Those sort of phrases clue your patient in that you're asking for that opportunity, that you are understanding them correctly and giving them the opportunity to correct you if you're misinterpreting. Because I recognize I have my own personal identities, and I am identifying everything in that lens because that's me. And I'm trying really hard to understand other people's lenses and what makes them them. And I think by having these little check-ins with these phrases, it clues your patient into, gosh, I want to make sure I get this right. And maybe sometimes rephrasing what they say to make sure that you're understanding them. And then open-ended questions, which I think Mandy, to a certain degree, had also touched upon with interviewing. And I think motivational interviewing comes to mind. And I'll give a little plug for the Academy's Behavioral Science Society that really actively is working on these sort of areas of how can we provide that care to our patients more effectively, and just motivational interviewing being part of that to make sure that you understand the patient correctly.
I need to throw you guys a curveball and throw 12 questions at you more often because those are really cool answers. I'm going to throw one other little corny tip that I always used, and it helped. I feel like warm up exactly what I think not exactly, but something like you're talking about, Michelle, is I'm picturing my dad as the patient, and my mom's amazing, but I guarantee that she told him, remember to say this, don't forget to say this. And I also guarantee that my dad didn't sleep the night before stewing about the appointment. So here he is coming in as the patient. He's nervous. He can't hear me until he gets these three things off his chest. So after the pleasantries, one thing I would always do is give them the floor. Is, hey, so just take a minute, if you will, and tell me like what's going on with you, like, anything positive, negative about your previous experiences. And then it was like you could feel them be relieved that they got to tell it all, and then they don't have to keep thinking about it. And then I also found that they could hear me better after that because they weren't running through their script over and over. So that's just another little thing that I would do. I think that speaks. I hope it does a little to what you're saying, Michelle, and the communication. All right, our final of 4 topics, and this is going to be about organizational practices and solutions. Samantha, maybe you could lead us off with, beyond individual clinicians, what can O&P facilities do to create environments that support culturally responsive care?
I was really excited about this final section because I was like, oh, this is my lane. This is my time to shine. And I'm really glad that you're talking about it because it's really awesome to see all of these names on the screen that want to think about this and want to pursue this. But really, if we really want to make an impact, it's the entire clinic, right? The entire practice, the entire department that truly needs to get on board, for lack of a better phrase, that to really make this move, to move the needle. And that is one of the things I do is provide education in a variety of topics. I would say the best way to start is for those in leadership, and I always look at my providers as being part of those in leadership to say, this is why this is really important to me. This is why I think everyone in our area, from our access team to those taking appointment phone calls, everyone needs to be thinking about this and aware of this. Here's some patient examples. We talked about storytelling ahead of time. Here's why this is important to get the whole team, the whole department, clinic to understand that this should be a priority. And then you can move into what that looks like, how these conversations move from that point. But starting the conversation is the most important thing. And then, yes, absolutely moving it into something for I say clinic because we function in the clinic space mostly, but the entire clinic to really be a part of creating this space.
Yeah, great. That's good stuff. Dr. Walcott, anything to add here?
Yeah, I mean, I'm listening to Samantha and thinking if I knew she was at my institution, it would be my responsibility to call her and say, "Can you please educate us?" Because I am the provider and I'm actually also the vice chair in our department and I'm going to dive into this. So if this is a topic you want me to steer away from, I will. But we had to change from DEI to something else because that is what it is. We call it now academic community engagement, and we do have resources all around, but it is much harder to find them. I think that was intentional to hide them or not be able to call them by their name. But that's where we need to, and my job for my department is to go find that education and those resources and bring it to not just my clinic, not just my section in sports medicine, but to my entire department. And there are people in my department too who aren't interested, and that's fine. And I think if you can create and provide some passive learning for them, they become more interested without realizing what it is they're interested in. But I think that's become much more challenging now uh, to, on a group level, on a clinic level, on a system level, to create that change because the resources are harder to access intentionally.
And Michelle, anything on just organizational practices and solutions?
Yeah, I agree a lot with what Samantha and Dr. Walcott mentioned. I've been at Gillette Children's for almost 20 years, not quite. And they've the really cool thing about this organization is they've always had part of their mission or vision to be inclusive to patients, family, and staff. How well they executed it just depends on the day, the year, the time, right? Like for each of us executing on that goal. But they organization wide have provided ongoing educational resources, or education and resources. To Dr. Walcott's point of the passive learning, we have newsletters that go out every week to the staff, and oftentimes there is something about inclusivity, and it's not stated in that way, but it totally is, and it's just a way to share that information. Whether or not that's intentional on our organization side, I don't know. But it really starts with our clinicians talking about it themselves. I remember, I'll give a little anecdote. In 2020, when I began, and I think most of us began learning potentially about the use of they, them, which grammatically was really challenging for me. As far as pronouns for a singular person. And it just took a lot of practice for us in our lab. And then practicing and making mistakes with each other, and then practicing and making mistakes with our patients and being humble about that. And I think the organization has, so like clinicians need to do some of the work, but the organization also has had required annual goals that we as employees have to do. This year it's embracing change. In past years, it was act first from love, or kind of embracing differences, or I'm probably butchering how they more eloquently stated those goals. But it really gave another opportunity, another touch point for people to do really meaningful things to create that inclusive environment for our patients and families and staff.
Thanks for that. Mandy, can you close us on the organizational practices and solutions?
Absolutely. So I've been answering this question for a couple years now, as my title has changed because of I'm in Texas and also in the US. So I think two things. Inward facing for workplace culture, you're with your colleagues for 11, 10, 8+ hours of the day. And it's also outward facing your culture with your patients. And so inward facing some actionable items that will bleed over to your patient interactions is have somewhere where you're posting an affinity month. Your specific clinic celebrates Women's History Month. You can print out a PDF off of the internet and have a billboard where you're posting it. You could perhaps do a employee spotlight, telling your patients in the waiting room about this particular employee, and bring that culture from the out facing inward. And so right off the bat, your patients are seeing this information in the waiting room that is perhaps culturally responsive from not necessarily their interaction, but just out in the world. Another thing you can do is incorporate an outcome measure into your intake paperwork. So I'm looking at here, just Google CMS, health-related social needs screening tool. And so it actually is a social determinants of health screening tool. And then you can, wherever part of the country you are, county, state, you can collate publicly available resources to give to your patients, perhaps if there's a need that is expressed in this particular outcome measure. So those are quick and dirty ways that you can really affect your clinic environment, inward facing and outward facing.
Yeah, that's great. Yeah, and I'll just add one too, is there's definitely the importance of the posting. It's in my opinion just a kind of, I think what I'm hearing you say is you're signaling that this kind of stuff is important in the
Correct.
house. Yeah. Then there's also this: if you're one of the senior clinicians or a leader, and I think it could be hard sometimes for humble leaders to recognize how influential they are, because sometimes your humility can get in the way of that. Is remembering that, hey, you're the lead clinician. People are watching you and going to model your behavior, and therefore you can really affect the culture. And then I would say, if you're one of the newer team members or a new clinician, one suggestion that I always have is nobody here on the team is going to get every segment just right. So I always recommend what they do is, do you love how Matt does this, you love how Scott does that, and you love how Kelly does this. Is you can pick and choose from each of those. So when it comes to this type of topic, is one of those people is going to be getting this right, probably. So you can model your behavior after that person who's kind of the star of that segment. So because we had such good answers, we are out of time. I will gladly look at the Q&A and do my best to talk with our experts and get you some answers. I really want to thank our four leaders today for sharing their experiences, really humble insights and thoughts. It was really great. And I think these conversations are important because there's not a single initiative or training. It's an ongoing commitment to understanding the people and the teams that we work with and alongside. And by strengthening this awareness, communication, and trust, we can improve both outcomes and the environment in which it's delivered. So I hope today's conversation brings about some ideas, reflections, and you can take it back into your organizations. Again, thanks for joining us with your valuable time, and hope you all have a great rest of your day. Thank you.
Thank you.